Hello and welcome back. The topic of this video is plan quality. So you've created an external beam radiotherapy treatment plan, and how do you know that it's good? What does good mean? So we're going to talk about that in this video, and there are some ways to define it, to define what's an acceptable plan, and even to rank plans in terms of quality. This is an area that's evolving a lot. There's a lot of research and development going on around this. So this is a snapshot of what it looks like, and I'm going to try to present some of the really basic concepts that we all should understand and be able to communicate about moving forward. So here we go. So in the last video, we talked about the volumes, so GTV red, CTV orange, PTV blue here. Let me talk about some of the limitations of that type of approach, because there are some. So for example, in a plan, I might have, let's say, a cold spot here in this part of the anatomy. Or I might have another plan where I have a cold spot in a different region, like here, let's say. So both of these plans, this plan and the other plan, they both would look the same. They'd have the same in terms of the DVH. Okay, but I think you can agree biologically those would probably not be the same. They'd have a different impact. Also in the OAR, so I might have, let's say, a hot spot here in the OAR, the brainstem in this case, a big hot spot. That would give you some DVH. Or instead of that, I might have many small hot spots. So those would give overall the same volume to that high dose. The DVH would look the same, but I think you can imagine that biologically these would also be quite different plans. So there are some limitations of this DVH approach. So we're going to explore in this video some other ways of describing and modeling the effect of plans on a patient. So when we look at these biological models, we look at two things. So tumor control probability, TCP, that's going to describe the probability of achieving control, local control. And then normal tissue complication probability, looking at the potential impact, adverse toxicity in an organ at risk that you want to spare. So we'll look at each of these in turn. All right, so first let's look at this, a very simple model for the tumor control probability, TCP, so versus dose. At a low dose, you can't control the tumor, so it's pretty small, probably 0. But then it goes up, reaches some dose where you start to control the tumor. So the TCP goes up, and when you go to a higher dose, you can't kill it more than once, so it levels off. The slope here is important, and also the point where the inflection is. So this is the D 50%, the dose where the TCP is 50%. And then the slope of the curve here, which is quantified by what's called gamma. So this is just a very empirical model. There's nothing biological behind it. It's just can be fit to data. It's good for looking at uniform doses, but there's nothing fundamental behind it. Now let's consider a slightly more sophisticated model. So here's the tumor I'm going to draw. It has some n number of clonogens that can go on and multiply. And we're going to try to control it with radiotherapy. So we'll deliver some dose of RT. After that dose, let's say the dose is D, small d. That's the dose delivered in 1 fraction of treatment. After that, maybe hopefully it's a little smaller. Here it is. So at that point, basically, we've killed some cells. So we have some that survive, the surviving fraction, SF, surviving fraction. And so now we have N times SF clonogens left. The surviving fraction, let's talk about that for a minute. You may know this from radiobiology. So I can plot, if I plot in a log linear scale, that's typically how it's done. It's not quite a line here. That would be exponential kill. It sort of has a shape, a curve to it. I'll try to draw it here. So it bends over. And the surviving fraction can be written like this. So it's alpha times d plus 1 times 1 plus d over alpha beta. So this is the linear quadratic model, the LQ model, or the alpha beta model, which just empirically, or there's some mechanistic underpinning, but it explains this. A lot can be said about that model. I'm not going to say much. I'm just going to kind of use it here. So let's give another fraction. After this other fraction, now the surviving clonages are n times SF times SF. You hit it twice. Let's deliver another fraction, and now it's n SF cubed. Okay, and so on. You keep delivering fractionated therapy. So I can go on, and at some point I would have delivered n fractions, small n fractions, and it was, so the surviving clonage would be SF to the n power, small n power, right? Okay, so at n fractions, now then I have surviving fraction, the total, e to the minus, and I'm going to use that LQ model formula. Alpha, little d, 1 plus d over alpha over beta, okay, times n to the nth power. Let me bring the n over here. So I get, let me combine it with this d. So I'm going to write that as nd. Nd, so the number of fractions times the dose per fraction, that's equal to the total dose, right? Total dose delivered, big D. So let me just rewrite that here. This is how people tend to write this. Now I just want to say something here. So at the end of this, on average, the final picture in the end, on average, we have n times SF clonogens. But what's the probability that we actually have 0 cells? Because on average we have NFs, but on average we have n times SF. But there's can be cases, because we're hitting it multiple times, and this is a random process, there can be cases where there are actually 0 clonogens, and we've got complete control. So let's look at that. To understand that, we have to look at Poisson statistics. Poisson statistics is a way of describing a random process. So you've got some counter that you're looking at here. So x, it can be 0, 1, 2, 3, or so on. And then you've got mu, Greek letter mu, which is the mean value if you take a bunch of measurements. So I can look at the probability for getting some number x. And that is given by this Poisson formula, which I'm not going to prove, but it's actually pretty fundamental. And I can look at that distribution of probability of seeing a value x, given that the mean value is mu. And it looks like this. It's non-Gaussian, and here the mean would be here, let's say. Okay, so given this probability for getting random that governs random processes, I can look at the cure, or the tumor control probability. So the probability of achieving local control, TCP. That TCP then would be the probability that there's 0, that I observe 0. So let's just write that out in the formula. So just plugging in the numbers, I would get e to the minus mu. Now mu is the mean value, so that was that n times SF that I showed in the last slide. That's the mean number of cells on average after being hit many times, times n times SF to the 0 power, right? Anything to the 0 power is 1, so that's 1. And divided by 1 factorial. 1 factorial is 1. Okay, simple formula then. So this is the formula we get. So let's go back then to our previous study here. So the TCP then is equal to just this simple formula. Okay. And I could write it out if I want. It's going to give me a double exponential, which is this formula. Okay. Oh, sorry, I left the n, big N out, but anyway, it's in there. So okay, so it's a double exponential. You can plot this. Here I'm showing this. You see here the TCP is 0 on this graph at low dose, and then it goes up, and at high dose here you get TCP of 1, and then it curves down in the sigmoidal curve. This is for n clonogens, alpha beta ratio, and alpha over beta ratio there. So I can change these. Let me change the number of clonogens. You can just play around with this. I'm going to change it down to 1 times 10 to the 7th. You can see the curve shift. Let me do 1, 10 to the 6th. It shifts down. Let me put it back up. You could change the alpha over beta ratio, 5, 3. Put it back up. I can change alpha, put it 0.4. That's quite sensitive there. So you could build a spreadsheet like this. This is very simple to build, and you can kind of play around with it if you want to understand this model a little better. But it's very simple in essence, just taking the LQ model and applying it to fractionated therapy. Okay, now one thing is that so far what I've kind of been talking about is something that would apply to a uniform dose like this, like we talked about before. But in practice, a lot of times we have a non-uniform dose, like maybe the tumor isn't completely covered by one single dose. So how do we deal with that? That's relatively straightforward. But let me just try to describe it. So yeah, if I have a tumor like this covered by some dose with some uniform coverage, then the formulas that I just showed you are the way to go. Survival fraction here, TCP here, and this D, big D, little d, they're just some number that applies to the whole tumor. Okay, but now I've got a tumor here that's a non-uniform. If it's non-uniform, I can kind of split it up into a grid like this. This is what we do in a planning system. We make a grid of points, and you calculate the dose in each of these little points. So it might be high dose here, another dose here, another dose here. And so it's broken up into these voxels, a volumetric cube, and there's they're indexed, so I goes 0, 1, 2, 3, and so on, right? So then the survival fraction in any voxel I can be written like this. It's just the big D, little d for that voxel. And then TCP then, the total TCP is TCP in voxel 0 times TCP in voxel 1 times TCP in voxel 2, and so on. Right? These are multiplicative because they're probabilities. They multiply together. And so then another way to write this is just with the product sign. That's this big pi. So product from 0 to n of TCP of the ith voxel. Okay? So and then here's the formula, all written out nicely. So, this formula, I admit, looks complicated, but the basics is pretty simple. So in the end, you can take this relatively complex dose distribution here in the corresponding DVH, and you can turn it into a single number for tumor control probability. So that has a great utility, as you can imagine. It's used in many studies. It can also be used during optimization of IMRT and VMAT plans, and we'll talk about optimization in a future video, but it can be used as to drive that optimization. Okay, so let's back it up and summarize then. So I showed you two different things. I showed you this empirical model. So we started out with that, the TCP just going up, and then this LQ-based model for TCP, where we did Poisson statistics, survival probabilities to get the final TCP. So some limitations. These are important caveats. So these results shouldn't be used as finite predictors for a patient. I'm pulling this from ICRU 83. There are many things that the model does not include: hypoxia, intertumor sensitivity, clonogen variability, cell growth, cellular repair mechanisms, vascularity, immune responses, many things. So it should only be used as a tool to estimate the effects of different dose distributions and compare them, which is more likely to achieve tumor control. All right, so now I'm going to go and look at this other dimension of the problem, which is the normal tissue complication probability, NTCP, which we also need to think about and model. This is relatively simple compared to what we just saw. So clinical data is available for the incidence of biological complications, and that's induced by uniform radiation of either part of an organ or the whole organ. So we have that data. So what we do is define an effective volume is the partial volume of the structure if that volume were uniformly irradiated to the maximum dose to the structure, it would yield the same complication probability as a non-uniform distribution. So here's the curve, the DVH curve, and the V effective is here. It's the volume getting the total dose, getting the maximum dose, which would give you the same complication probability. Okay, so it's kind of empirical. There are caveats, just like there were to TCP. So results shouldn't be used as finite predictors for a patient response. The model builds around clinical data, and there might be uncertainties. So let's talk about another concept for normal tissue predictions, and that's the equivalent uniform dose is the uniform dose that gives the same cell kill as a non-uniformly irradiated target. So this is not derived from cell survival models. It's just empirical. V little I is the partial volume with the absorbed dose DI, and it goes by this formula. And A shows the dose response. It parameterizes the dose response and is fit to published clinical data. And it's positive for normal tissues, negative for tumors. So it can be used for both. All right, so let's kind of summarize this whole thing then all together. So I showed you dose response curves, right? Or give you a model for them and look into probability versus the dose. The first curve was for tumors, right? So that looked like this sigmoidal curve, and that was the TCP, the tumor control probability. The second kind of curve might have a similar shape, and that would describe the normal tissues that you want to spare, NTCP here, for example. And so the split between these is called the therapeutic window. That's where you can safely irradiate, achieve tumor control without the complications. So this then is one of the major goals of advancing radiotherapy, is to push these two curves apart. Maybe you do that through physics by maybe better localization of the dose, better control of where the delivery is. Maybe you do it through biological targeted agents that give you a dose enhancement so that you can achieve the same TCP with a lower delivered dose. Or maybe you try to use some kind of agent that helps you spare normal tissues, so a radioprotector in some way. So all these different approaches are brought to bear on trying to push these two curves apart so that you can deliver safe and effective radiotherapy. So I want to extend this discussion a little bit. So you might be presented with a plan like this. You're looking at isodose lines, and based on what we said before, theoretically, I could give you a TCP, tumor control probability value for this plan. But that's still not quite enough, because I haven't told you whether this was the best plan that I could have achieved. Maybe I could achieve more sparing of the brainstem or the chiasm or the optic nerves in this plan than I did. And TCP isn't going to, or NTCP, those aren't going to tell me much about that. I don't know whether I've done the best that I can. So that brings me to the topic of plan quality and how do I assess the quality of a plan and develop metrics for that. And this is very much a work in progress, and so I'm going to present things kind of as they stand now, but this will change quickly. This is early work from the group at Johns Hopkins, Bin Wu et al. What you're seeing here are 3 different patients, head and neck cancer patients, and you see the anatomy is quite different. The green is the planned target volume, and the red is a parotid gland. You can appreciate from this that patient C is going to be a case where you can achieve more parotid sparing than with patient A. So the goal behind this work is to predict what kind of plan quality you can get for these different patients given the anatomy. So there are metrics that have been developed that can describe and quantify the achievable plan quality. So here's an example of the application of this. So there's a clinical plan shown in the solid, and then it's been replanned, and they've achieved more sparing in the parotid gland. They've done that for many patients, and they show the effect over population. Here's another study from Kevin Moore at University of California, San Diego. They did a reanalysis of the prostate dose escalation trial, RTOG 0126. They went through with one of these knowledge-based planning algorithms to ask which plans can be improved. And what you'll see here is there's a cohort of high-quality plans where you really can't improve in this case, rectal sparing. But then there were another group of plans down at the left here where you can improve the plan quality quite a bit. So here you can look at some of the numbers of patients involved. 43% of patients had a predicted 5% excess risk that could have been eliminated with replanning. And then there were an outlier group, 1% of patients that had actually 15% excess risk. So in the future, this will likely be used more. It's already there clinically in some vendor products. And so it's good to understand the basics of this. All right, so those are some of the fundamentals of plan quality. I'm going to leave you with a little bit of further reading here. This is a vast area of literature. As I said before, it's an area of research and development that's really evolving and moving quickly. So this may look quite different in a few years, but hopefully with this video you've seen some of the basic concepts, and I don't think these are going to change anytime soon. So this should hopefully form a good solid basis for your understanding further. We'll see you in the next video.